Dr. Zain Chagla, who is an infectious disease physician and an associate professor at McMaster University. He's been instrumental in guiding public health responses to infectious diseases and is a sought-after expert in antimicrobial stewardship, vaccine strategies, and pandemic preparedness. So we're going to get a talk here, an update on the prevention of respiratory disease and COVID-19. So please put your hands together for Dr. Zain Chagla.
We'll go through an update on the prevention of respiratory disease and COVID-19. And so I'm a physician by background. I work in a large tertiary care hospital. And, you know, I think I'm going to try to go through all the vaccines as they appear, but really talk about the burden and what this really does to us. I know a lot of you have friends and family that probably have suffered from some of these viruses, but in healthcare, it can become really problematic as these viruses circulate and really challenging on our healthcare system, which is already under incredible stress. So these are my disclosures. Content, there is an honorary today, but the content is my own. So, you know, all of us think of cold and flu season as that, you know, that ugly thing that rears its head from October to March. If you have kids, it's the time when they're constantly sick and you're constantly sick with them. But again, in healthcare, it is really a difficult season. One of my jobs is dealing with corporate flow, and you know, we know this part of the year, our emergency rooms get backed up. We can't get people out of hospital fast enough, and really the quality of care does suffer, and our staff feel a lot of moral stress working through the season. So this is what happened this year, and this is what respiratory season looked like this year. These are two stats. One from this is from a network through Kingston Public Health that looks at ED visits and inpatient stays. And you know, just to say, these are what's expected. The green, yellow. The green is the baseline based on the last 3 years. The yellow, 1 standard deviation. The red, 2 standard deviations. And the black is what happened. And so we did see a pretty, you know, that October, November time was actually a little bit less than expected. Then we saw a surge that happened that was actually a bit worse than expected through January and February, and still continues actually to be a bit higher than expected. And a lot of that is now actually influenza that is circulating and leading to a significant amount of hospitalizations. And you know, the figure on the other side is ED visits, just to say that, you know, that correlated quite well, that you know, we saw a significant surge in ED visits going through the Christmas season, but still a significant amount of ED visits, a bit higher than the baseline, again, from a late influenza season that's still continuing along. These are a number of figures, you know, looking at what's currently circulating. So again, going into the respiratory season, COVID-19, unfortunately, COVID-19 does circulate, you know, although it has seasonal trends to circulate through the year, was the higher one. That's the green, the blue, RSV, and then the other is the red. Sorry, is influenza. And you know, again, this has actually been a very bad influenza year, one of the worst on season. Certainly one of the worst post-pandemic, that again is continuing along and driving up a significant amount of the hospitalizations. We had, again, if you look at acute COVID-19 hospitalizations, a big rise, again, as expected in January, influenza, a larger rise, and then RSV, again, a significant rise, which is now tailed off. And we'll talk a little bit about RSV and the changing dynamic we're starting to see with it. And this is actually it, that slide. So, you know, on the right side is what was 2023-2024 RSV season, and it's pretty characteristic season in the context that the group that suffers the most with RSV in terms of hospitalization are the youngest of children. So we know that about 70% of the hospitalizations in Ontario are children under the age of 5, predominantly children under the age of 1. You know, they have very immature lungs. It circulates, it co-circulates often amongst their siblings and then hits them in the household, and they get bronchiolitis, and it is actually a fairly common cause, one of the most common causes of hospitalization amongst pediatrics in respiratory season. And so, again, on the right, we see 23, 24, where we see the group that's overrepresented being the young kids, and then the group in blue being people over the age of 65. The left is this year's RSV season, and you see something actually happen about halfway through the season, which is a bit different. That the children start off as number one, and then go to number two, actually, as we go through the season. About January, you see the flip over. And then older adults actually see the higher burden of RSV hospitalization as of January. Does anyone know what the difference is this year? And I'll give you a hint. It's something that happened to the kids. It's nothing to do with the adults. Yeah. So Ontario started a universal RSV vaccine program in young children using a monoclonal antibody, Beyfortus. And this was actually seen globally when Beyfortus was rolled out in countries that got significant coverage, like 95% coverage of Beyfortus in young children under the age of 1. They saw essentially RSV hospitalizations eliminated in young children. Now, in Ontario, because it was the first year, there's still distribution issues, there's still counseling, and it's taken its time. The last estimates I saw were somewhere to 40 to 60% of the eligible cohort was immunized and continues to be immunized. But just to say that still has relative effects on the system. So, I would actually expect as now we get through many children being vaccinated, now every child that is born in a hospital has an offer for RSV vaccine at the time of their birth. As we get to higher and higher rates of vaccination, RSV is going to be an older person disease. That's what we're going to see in hospitalizations, and that's what really is going to be the burden of disease that we see going forward. So many of these viruses have again, make people, especially in the middle age, feel a bit sick, but we do know older individuals and certain individuals have worse outcomes. And some of this has to do with their medical history. Some of this is their functional status, so how they are prior to that infection. Their immunity, so if they are immunocompromised. Some people are very prone to inflammation. Their structures and supports, and for example, with COVID-19, we saw communities that were disadvantaged, sheltered, suffer the most consequences despite being, similar age and status to other individuals. And then non-respiratory symptoms, and we'll talk a little bit about how things like cardiovascular disease are very interlinked to the spread of respiratory viruses. So the burden on healthcare, well, we have, isolation. We in this region and others have a limited amount of private rooms. When these patients come to hospital, we have to put them in private rooms or at least cohort them with someone else. So all of a sudden, our rooms get slashed in half, basically, once individuals come to hospital with one of these infections. Sometimes we can find a similar room, but sometimes we can't. And that's actually really problematic, right? We don't have enough beds for people currently, and then we lose some of the beds due to isolation as it goes on. We have outbreaks, unfortunately, which cause more isolation, which cause wards to be locked off. There's financial burdens, and I'll talk about the costs. There's infrastructure burdens, again, in terms of our health systems. There's the domino effect, so as we jam up emergency rooms, as we jam up hospital beds, that unfortunately leads to surgeries being canceled and other downstream effects. And there's human resources, so the people, the staff and care for these individuals are also suffering with respiratory season. Thankfully, not getting many healthcare workers don't get as sick because they're not carrying many of the comorbidities. But just say they have to take their time off, they have to isolate too, and that often has its own challenges with structuring the system. So this is data from a number of different networks, CIHI and Ontario-based data as well as Alberta-based data. But per case, a cost of an influenza case on the healthcare system is $14,000 for a hospitalized case. RSV is about $12,000. COVID-19 is $24,000, and community-acquired pneumonia is about $12,000. And compare that actually to the average cost of hospitalization for a non-respiratory illness of about $8,000. I was reviewing a bit of data just before this for another presentation. The number 10 reason still in 23-24 from CIHI for hospitalizations, long hospitalizations in 65-plus-year-olds is COVID-19. So, and the number one is COPD and bronchitis, which is often a combination of these other viruses. So, there are profound health systems costs to these and health systems utilizations secondary to these viruses and community-acquired pneumonia. And, this is what we describe as coded illnesses, right? So when we do a CAI study, you use coding to say this person had pneumonia or COPD or COVID-19. But we know these illnesses don't have specifically just respiratory roles. And there is this two-way relationship. So, for example, and I give the example of a person with COPD, FEV1 is slightly lower on medications, they get RSV. What happens? Well, they get hospitalized, they get on antibiotics, steroids, they come out a little bit weaker and a little bit worse. And there's actually really, really beautiful data suggesting their FEV1 goes down permanently after that hospitalization. It doesn't come back up. They recover a little bit, but they don't go back to their pre-morbid baseline. So that person with an FEV1 of 50 has an FEV1 now of 40. Well, what happens when they get that influenza infection next year? Well, they're even more vulnerable now. And so that cycle continues along and along and along, where their comorbid disease gets worse. That makes them more susceptible to these infections, and it spirals and spirals and spirals. And that's not just COPD, that's things like frailty and geriatric care. That's, as we'll talk about, heart disease and myocardial infarctions. So this was a really beautiful study that was done in Ontario. They looked at public health data through OHIP as well as health utilization data. And they looked at people, they controlled them for the year before they got the respiratory illness and 7 days after they got the respiratory illness. So that was the control themselves. And they compared that to the first 7 days after getting that respiratory illness. So the first 7 days after getting influenza, RSV, this is prior to COVID. They saw there was a 6-fold increase in heart attacks in that first 7 days after getting influenza, a 3-fold increase in heart attacks after getting RSV, and in other viruses about 2.7 times. This is data that's been replicated in other parts of the world, and it in fact also correlates quite well to cerebrovascular disease, so stroke as well. And lots of mechanisms, which I'm not going to go over today, but just to say that this is not a trivial piece. We know that these viruses cause more than just that. So with RSV and influenza, we see lower respiratory tract, cardiac, bacterial infections, readmissions, and unfortunately deaths, which are prevalent during season. And I want to end with this proof of concept before we talk about the vaccine. So this is a study that was done actually at McMaster with Salim Yusuf's group and Mark Loeb, who was the primary author, that took individuals with NYHA 2, 3, and 4 heart failure and randomized them to influenza vaccine over placebo. And this was done in low and middle income countries because of the fact that ethically you could not randomize in somewhere like Canada where the vaccine is widely available and would be recommended in this age group. Thankfully, from the ethics standpoint, many of these countries had no access to vaccines, so the trial at least gave 50% access to the vaccine during that interval. When we talk about cardiovascular studies, and you probably maybe have heard some here this week, and we talk about MACE, so this my major event, myocardial infarction, cardiac death, et cetera, statins or anticoagulants, et cetera. They used MACE here as the outcome. So they didn't care if these people got influenza. All they cared about is did they have a cardiac event or not during an influenza season. And so they randomized people to this, again, primary outcome of the composite of cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for CHF. That is the only outcome. They didn't care about if they got influenza, pneumonia, they didn't test for it, they didn't look for it. They just said, if you had a vaccine or placebo, were you more likely to have a cardiovascular event or not have a cardiovascular event? And when they did the full analysis, it was a 2-year study, they actually did not see a difference. But when they broke it down for when people had these events, which was the marker, so giving an influenza vaccine in in the summer here is not going to help prevent a myocardial event. If we think that you get the myocardial event from having influenza, it's not going to help in the summer. But when they looked at peak influenza season, they actually did see a significant difference in that myocardial endpoint. And so that's an important proof of concept that giving an influenza vaccine during, and again, these are high-risk cardiac patients, during influenza season can theoretically have an impact on cardiovascular events for patients. Not on influenza, on cardiovascular events. And so again, as we're talking to patients, counseling patients, it's not simply, preventing getting sick for a couple of days. For some of those vulnerable patients, it's their disease control, which you're counseling them about. So going through the vaccines, influenza vaccines, pretty simple. Thankfully, we are coming out of influenza A season, although B is probably going to show up soon. We give vaccine to reduce hospitalization and death with influenza. Early estimates this year are somewhere in the 40% range. Although we have to see what the full season's data is, especially as we've had a fairly significant season. There's lots of different types. The one change this year, many of you have noticed, is that the enhanced vaccines for 65 and older aren't just the adjuvanted or aren't just the high-dose vaccines, but are adjuvanted and recombinant. And then obviously any choice for anyone under the age, theoretically fall. I think again, influenza season is largely ending. So if I gave this talk a month ago, I would say if you have people asking, probably still not a bad idea, because considering we had such profound activity even through February and March. Now it's dropping, thankfully, and again, recommended for everyone. I'll spend a little bit of time on RSV vaccines. Again, when you're thinking about who to offer this to or who to think about for this, this is a large U.S. registry in RSV net, and the people that were hospitalized with RSV, number one, were older, but number two, all had a comorbidity. So the vast majority at least had one comorbidity. Many had three or more, and you see the ones that run together, and not surprising that these predispose people. So again, when you're trying to build that profile of the person that you're really trying to push for getting their RSV vaccine, that's, just think about people with comorbid disease along with their age. So there are two RSV vaccines that are approved. I'm not going to talk about the Moderna vaccine as it's approved, but not on the market yet. So we have Arexvy, which is the GSK vaccine. This was a large multi-center randomized clinical trial. I will say both of these trials are different, and so hard to compare side to side. So just as as much as we've attempted to, their endpoints are a little bit different. The two RSV vaccines we'll talk about is Arexvy, which is the GSK vaccine, which is an adjuvanted RSV vaccine to RSV-A, and the Pfizer or Brisvo vaccine, which is an RSV vaccine that's non-adjuvanted to RSV-A and B. Both are similar RSV A and B, and again, both of the trials looked at kind of the endpoints for both. This trial randomized again to vaccine or placebo and saw a significant reduction in RSV lower respiratory tract disease, and that was a clinical and symptom-based parameter. Safety was fairly similar, although because it was an adjuvanted vaccine, there was a significant amount of arm side effects, particularly pain and erythema and swelling at the injection site. Not unexpected. It is the same adjuvant as we use in the shingles vaccine. And this is the Brisvo vaccine. Again, the Pfizer vaccine used a symptom endpoint of 2 or 3 symptoms, again, randomized 1-to-1 to receive, and they were followed for 2 RSV seasons. And again, they saw a reduction both in 2 and 3 symptoms of RSV disease amongst individuals who had vaccines. And so again, hard to compare side to side, but both 80+% in that more severe group. There were less side effects in this vaccine, again, largely due to the fact that it was unadjuvanted, but you see kind of the pain in the injection site, redness and swelling a little bit better than the GSK vaccine. Longer-term data, Arexvy has, the GSK vaccine has, I'll show 3 seasons data. There was a second arm of this trial where they gave a second dose of vaccine in the second year to individuals and actually did see no difference between individuals that got 2 doses or 1 dose. And so this is where the recommendation right now is just for a single dose of vaccine. But again, no difference and significant protection that lasted about 75%. And again, 2 years of data for Brisvo, the Pfizer vaccine, about for those moderate to severe cases, 77%. A little bit less for the milder cases, but again, not what we're trying to prevent. And then this is actually third season, full season data from the Arexvy vaccine. And again, just saying that you see that complete season about 70%. Protection with the seasonal covariant data, and then for medically attended RSV vaccine, RSV lower respiratory tract disease, about 80% protection. In fact, only 9 people in the trial that were vaccinated to 3 years were medically attended RSV visits. So important numbers. Real world data, more is coming out, but this is one of the studies from last year. But really suggesting that 70-80% is actually borne out in practices when you start looking at hospitalizations for RSV. So NACI recommendations are those greater than or equal to 75, particularly at increased risk of RSV disease, and other populations 60 to 74. Discretionary in the context of their healthcare provider. I think as we talk about people with comorbidities, more comorbidities versus less comorbidities, that's probably one. People that have fairly severe comorbidities, so bad COPD, really bad heart disease, where even pushing them over the edge a little bit are fairly significant. You may want to think about it more than not. But again, this was prior to the current recommendations. The more updated recommendations, which are about a month old, do 2 things. One is actually recommend the provinces fund 75 and over, and so we'll see if that actually happens. But really does put a motivation to fund it. That you continue to actually fund 60-year-olds plus who are in chronic care facilities, as we see RSV spread in chronic care facilities, and actually there is now an approval for the Arexvy vaccine for 50 to 59-year-olds. Who are at increased risk of RSV, and so considering them in that age group of people with physician or healthcare recommendation. That's the only one licensed so far. The Pfizer vaccine may be licensed down the line, but really, even that 58-year-old who's on home oxygen for COPD may be someone you want to think about getting vaccinated, as part of that newer recommendation. We do have Ontario funding for a certain number of vaccines, particularly patients in chronic care facilities and patients with high comorbid status, so organ transplants, glomerulonephritis patients, or patients on dialysis. And so many of their home programs have been doing that work and vaccinating that population. So again, if you do have a patient that has one of these issues, it's worth it to inquire with their facility or their dialysis center to see how they can access vaccine. I think that it's always important that we talk about real-world considerations, and I think I work in a high-risk respiratory clinic. It always crosses my mind the cost for the unfunded vaccines. But at the same time, I think I worry about it more than my patients, and I offer it, right? And so, we always have the discussion at the end of every encounter, regardless of why they're seeing me, is, are you up to date with your respiratory vaccines this year? And shingles vaccine, usually. And we talk about the reasons for each. I'm happy to write the recommendation, but I've had the conversation. I've left it to them to say whether or not they feel it's important or not. Co-administration, so again, NACI is allowed for co-administration of all respiratory vaccines, may want a space from non-respiratory vaccines, routine vaccines, just because, again, the side effect profiles may overlap. And really attitude. So I think there has been more recognition of RSV over the last couple of years, but if you look at surveys still, a lot of people kind of recognize it, that childhood disease. They kind of say, how's this different than influenza? And so, even talking about it, regardless of whether or not you're recommending a vaccine, just talking about it is still important for that patient's journey to make sure that it's addressed. Pneumococcal vaccines. So I'm not going to talk about the old polysaccharide vaccines because they're largely not recommended anymore. This was the only real important randomized clinical trial in pneumococcal vaccines that showed what their profound effects are, and this was a randomized trial of Prevnar 13 in adults, so 13-valent pneumococcal vaccine. And the bottom line was they actually showed a reduction in all-cause pneumonia with getting a conjugated vaccine. There's actually no other vaccines, so the prior polysaccharide vaccines have never shown this trend. And it's actually important because all-cause pneumonia, I bet we think about 40% of pneumonias are pneumococcal pneumonia. There's also viral pneumonia, aspiration, a smattering of other organisms. And so to show a reduction in all-cause pneumonia really means that you're reducing that 40% so significantly that it skews the numbers to the point where you see the all-cause. And so this is largely where the platform for conjugated vaccines came about, and really why they're now becoming the recommended vaccines for all populations. And in fact, most of the current vaccines, so we have PCV15, PCV20, and PCV21 now, they're all based on this pathway of the data from PCV13 showing that it prevented all-cause pneumonia, and then immunologic studies saying that now you can add 2 more serotypes, 3 more serotypes, 5 more serotypes on top. So none has been trialed as an all-cause pneumonia prevention, but just kind of piggybacked on that trial with better immunologic outcomes for other serotypes. One of the questions is, why do we add? And so these are kind of the serotypes we see out there. And just to say, some of these are the ones that are circulating. So for example, this is what circulated in 2020 in Canada. You can see some of those serotypes are actually outside of PCV 13 and 15, and even 23. 23 makes a poor immune response, so it's not to be relied upon even for some of those. And so this is where the platform continues to increase serotypes in order to catch up with the ones that start circulating as we vaccinate more populations, but still want to reduce disease amongst older adults. And again, there's some also associated with drug resistance, some that we see more in people with CAP. And just to say again, it is this catch-up game that we want to make sure that the serotypes we're not covering are covered as we shift towards them more and more. I will mention PCV20, which is the current vaccine, which we mentioned on that last slide. And then PCV21, which is a little bit further out, which is now available, I think, through Merck, is another one that compared to PCV20, where, again, outcomes were similar in the immunologic studies, although there were some more serotypes in 21 than 20, which were favored in that group. I'm not going to go into why this matters too much, but depending on your age, your population, and where you are in Canada, you may have certain types that are in PCV20, you may have certain types that are in PCV21, you may have certain types that are shared. And so this is where that decision-making can get a little bit tricky in terms of what to recommend to what population. But NACI has made it very simple. Everyone should either get a dose of PCV20 or 21 who's at risk. And so this is regardless of vaccine history. So a lot of people have been immunized. My experience is usually, I got something 5 years ago. My family doc gave me something. It's usually polysaccharide vaccine. For everyone should be getting a dose of 20 or 21 over the age of 65, or if they have a condition of concern. The optimal time is ideally a year. It should be a year. But if they're kind of going under chemo, even as short as 8 months. But really everyone who's been in that age group, either over 65 or has a risk condition, should be getting a dose of PCV 20 or 21, which is a big change from prior. In Ontario, there is public funding for PCV 20, not 21. So really those at risk can get a single lifetime dose between either the age of 5 or 64 or 65 and older. Technically, this is people that have not received a publicly funded vaccine in Ontario before for pneumococcal vaccine. The reason I say technically is, as many of you know, other than COVID, we don't track vaccines very well at all in Ontario, and so no one actually knows who's gotten what vaccine in the past. I don't quite understand why they included that. some people do ask, what are the conditions I would give it to under 65-year-olds? And these are some of them. You will see things like diabetes here, which, again, you would not really recognize, but, again, fairly poorly controlled diabetes can be a risk factor for severe community-acquired pneumonia, chronic cardiac disease, cirrhosis, malignant neoplasms, obviously if they're immunocompromised, but there are some, chronic conditions we deal with on a day-to-day basis where people are actually funded and should be getting a dose of the vaccine. Lastly, we'll talk about COVID-19 vaccines. So NACI's recommendation, so we used to have this, fall and spring recommendation. NACI's actually made it quite clear that they're going to just require, 1 dose or 2 dose yearly vaccines. And so 1 dose is over 65 or people with a high-risk medical condition that they get 1 a year. 2 a year is those over the age of 80 or who live in long-term care or who are immunocompromised. So there will not be, spring and fall recommendations anymore. This is until 2026 when they look at this again. These will be the long-term recommendations, which actually makes it simple to who to plan for in that sense. And if people are off cycle or on cycle, you just have to say, okay, do you need 1 or 2 basically to finish your routine this year? That 65 to 79 is a discretionary recommendation to get a second dose. Again, people with higher comorbid status, fairly frail in that group, probably would benefit from that second dose. Healthier people in that age group, you might make a recommendation to hold off and just get the yearly dose when it's updated. I will say vaccine uptake is not great, and I think probably we see this. So this was last year's vaccine uptake. We actually don't have great stats for this year. But even in that 80 and older group, which we would think is the highest risk, as providers, we can get about half of them immunized. So that's at least half of 80-year-olds that decided against the COVID-19 vaccine when they're probably the group that's at the highest risk of having bad complications from the disease. I was looking at US data again prior to this for another presentation, and it's actually even lower. Even long-term care individuals in that study they have more up-to-date stats. Long-term care was 25%. So, frailest of frail was 25%. It's interestingly 40% in influenza, so there is a preference not to get this vaccine over the influenza vaccine. Just to say, even though someone's frail, they may not recognize the need to get this vaccine. This is older data, and again, I haven't included data from this year, which is starting to come, but just saying that, even this is data from the Netherlands, where they saw, even in the context of people having had prior COVID-19, prior vaccines, they still saw a 60% incremental benefit for getting an updated vaccine in a frailer population. In fact, in their whole season in 2023, there was only 8 ICU admissions of individuals that had gotten an updated vaccine in the country. And so really, really important to say, even in those patients, I've gotten COVID, I've had my vaccines. If you're at a risk group, there's still incremental benefit. Earlier, again, some of the data I've seen for this year is suggesting it's about 40 to 50% incremental, but still better than nothing in that group. And then lastly, therapeutics, I think we all recognize, are still available. They're through limited use code for ODB or privately funded throughout. Remdesivir is still available through community care access teams. However, very, very intensive in terms of nursing utilization and infusion centers, and so is largely second recommended therapy for those who cannot take a Paxlovid. And then for oral influenza therapeutics, Tamiflu is also considered for those at risk. One would ask, again, without testing for influenza, who would you give Tamiflu to for upper respiratory symptoms? And, for at-risk people in kind of, again, February, March, where we saw just raging influenza and nothing else, I would have given it. I wouldn't have even bothered, again, testing would have been nice to have, but not a barrier in that context. And again, it was a really bad season. We saw a lot of hospitalizations. So again, if it could be prevented, it was worth it to prevent in that context. So, just to conclude, there's a new toolkit of respiratory vaccines that are very different than 5 to 10 years ago. I tried to hopefully say that this is not simply just short-term respiratory illness, but there's long-term impact. Engagement is across all sectors. So I, as a specialist, I counsel. I give some of these vaccines, but I'm not the one that's the primary. but they'll go back to their primary care provider and say, okay, I got told to get this, I should get this. And similar with you guys, if you're seeing patients, even if it's pneumococcal vaccine where you may not have access to public funded vaccine, you give their influenza, you give their COVID, and you say, hey, you're actually probably due for your pneumococcal. Go back to your provider and ask, right? That full 360 approach to that patient at least helps with that patient being engaged at multiple levels so that they don't fall through the cracks. And again, I think we see benefits for disease, costs, and chronic disease management. And I think this is the other area we'll see more and more coming out, that vaccines to just stabilize chronic disease are probably going to be a bigger and bigger impact.